أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم فإن مع العسر يسرا إن مع العسر يسرا. So verily with hardship there comes ease, and verily with hardship there is ease. Brothers and sisters, colleagues, fellow healthcare workers, fellow frontliners, Assalamu alaikum wa rahmatullahi wa barakatuh, and good evening to you all. So first of all, thank the Almighty for this opportunity, and I thank the MHI team for organizing this thing. As you all know, it's the first session that we have, and the first such workshop. And therefore, as things go, your active feedback as well in the comment section is also valued in terms of helping us improve. As you all know, today the topic is tackling COVID-19, the coronavirus, the pandemic which has come upon us right now. And this session is supposed to be more of an informal session in terms of a discussion. Like I'll start off with explaining a bit and giving a short talk on the do's, the don'ts, and the PPE. But after that, I look forward to us discussing about many difficulties we face or questions that we have, so that we can effectively find solutions to this. So the basic outline of today's session is we'll just look at a quick introduction to the pandemic. Then we'll look at specific advice to us, the healthcare workers, and like I said, especially the frontliners, the do's and don'ts in general, which will cover advice to us as well as the do's and don'ts, which we can then take forth and advise families, patients, and friends, so for the general public. And then, inshallah, we can have the question and answer session. So to start off with, before coming to the depth of it, we all know the pandemic, what it is. We all know the coronavirus, the group of viruses, the first case being detected in Wuhan and then spreading rapidly across the world to now be classified as the pandemic that it is. And we all know, we all have an idea of how this virus is spread and how it exists, but we will look at the depth. Since we are all in the career somewhere or the other, we'll look at the depth of the pathophysiology and try and understand exactly what this coronavirus does that makes it so virulent. Like, what is it about this virus that makes it, gives it such a high potential to spread compared to other viruses or other bacteria that we encounter. So let's just start off really quickly, looking at the symptoms, first of all, of COVID-19. We all know that we've been told it's a flu, it's an influenza, and cough, flu-like symptoms, fever, generalized body malaise, generalized weakness, were all the things that everyone's spoken about in recent times. But coming very specifically, so if you can focus on the slide projected on the screens in front of you, you'll see that these are numbers that have been put down according to studies that have been done. This includes groups in China, Italy, the United States, and other stricken areas. And what has been noticed is that cough has been one of the most presenting, like greater than 80% of patients have presented with cough as one of the presenting complaints. Fever is in around 50% of patients presenting to the ER, and more than 80% through the course of the illness. Just a point to note here is that a lot of people you will hear, they'll say that, oh, this person is sneezing and has a cough or is weak or has some myalgia, but and a fever, nothing. They don't have a fever, so it's not COVID. So fever is not by the rule. You can have coronavirus without developing a fever, because that relies a lot on the immune response of the body. Shortness of breath tends to be a late presentation in terms of it develops around 2 weeks after the onset of the disease. And then there's other non-specific symptoms, which include a sore throat, myalgias, diarrhea, loss of sense of smell and taste is one of the latest papers that have come out. So the incubation period of COVID-19 is 2 to 14 days with a median of 6 days. And approximately 1 week after the mild symptoms is where the severe symptoms may develop and the person may decline, or where recovery may then start and the symptoms will then disappear. In terms of risk factors, we've already been told, we know that the elderly greater than 60 years are prone for this. Any comorbidities, so any patients with heart disease, lung disease, smokers, diabetics, patients with CKD, patients on chemotherapy who have a malignancy, and many other patients with severe comorbidities are prone for this. And immunocompromise of any form. This includes HIV, malaria, cancer, things that I mentioned, as well as people who are on immunosuppressant drugs as well. Anyway, jumping straight into the pathophysiology. So the thing to understand for healthcare professionals is 3 primary things. This virus, the reason why it's so virulent and why it's affecting systems so much is it has a multi-pronged approach. That's what we can call it. That the hypoxia that we are noticing in this virus is not only secondary to the acute respiratory distress syndrome, like the ARDS that is occurring. It's not only because of the difficulty breathing or the respiratory compromise, but so firstly, we have heard of the cytokine storm that happens where there's a sudden inflammatory response where cytokines are called, and the inflammatory response in the lungs is what leads to the respiratory distress per se and the inflammation of the respiratory system. That is one mechanism which is easy to understand when you consider the pathophysiology. But there's also proof that shows that microthrombi in the vessels, in the pulmonary vasculature, are formed, which thereby cause small blockages and give a sort of a mini pulmonary embolism sort of picture. And that is another contribution to the ARDS, because every time those pulmonary vessels are blocked by those microthrombi, it causes extravasation. Because of the interstitial pressure, it causes extravasation into the lung parenchyma, and that is also something that's contributing to the diffuse infiltrates that are being seen, and therefore the acute respiratory distress syndrome. But the third thing, and an important thing to think about, is that coronavirus has been noted to break down heme as well, and in doing so, it reduces the oxygen carrying capacity of the blood, and that is one of the primary things to why we see a lot of silent hypoxics, what we call silent hypoxics, in terms of they do not have the respiratory symptoms, they do not have the difficulty breathing or things like that. But if you check the saturation, the oxygen saturations are dropping. This is because of actually the oxygen carrying capacity, the heme portion of the hemoglobin, which is causing this decline. So for healthcare workers, as I mentioned, silent hypoxia, that's an SpO2 of 60 to 90%, while the patient appears very, very comfortable. And some of them may have very profound hypoxia to the level that we had one patient who actually developed hypoxia to the level of developing peripheral cyanosis, but denied shortness of breath. And the reason I've mentioned this very specifically, of course, all the other constitutional symptoms come into play, but this specifically is because these are the category of patients that are likely to be missed when they present to us, be it in the ED or be it to a clinic. And next, when you look at the common vital sign abnormalities, there is hypoxia, which we mentioned, there is tachypnea, low-grade fevers. So another thing to think about here is most of the patients who are presenting with COVID-19 do not have extremely raised temperatures like of the range of 39 and above or 40. They're mostly playing around in a low grade range of between 37.8, 38 to around 38.5. And they tend to have tachycardia. Yeah. The important thing to think about from our perspective, so now we come to the do's for the healthcare worker. The first important point is that we must isolate all patients with any of these above signs and symptoms, and we must provide surgical masks to those who are symptomatic with respiratory symptoms. The important thing to think about here is wherever you may work, be it in our major hospitals. So the Aga Khan Hospital right now, Muhimbili National Hospital, have designated areas which are known as isolation rooms. Of course, there is much to be desired in terms of negative flow and all those things, but at least these areas are available, which make a place available to isolate patients immediately to continue the triage process. So similarly, be it our hospitals, be it Hindu Mandal, Ibrahim Haji, Regency, or our public hospitals as well, or clinics, or wherever it is that we are working, we need to isolate a designated COVID area. The more isolated it is, the better, so that these patients can be kept separately completely from anybody else. So one thing to really stress on, and one of the primary points for me, a key point in today's talk, is that so far we have been running a triage system for fever, cough, cold, or these symptoms, or patients who present with something like a flu or something like a respiratory syndrome. The scary part is that right now we have been getting patients who can present with anything. If you see this sentence which says, when the disease burden grows in the community, you must then assume all patients have it and protect yourself accordingly. So the rule we learned in med school about female patients, for example, that any woman in her productive age is pregnant until proven otherwise, has now an application to the general public as a whole, that any patient presenting to you is COVID-19 positive until proven otherwise. Because in the last 2 weeks in the EMD Muhimbili, this includes patients who had a DKA, but then were COVID positive, had acute coronary syndrome, but then COVID positive, and a lot of other presentations as well. And this makes it scary because, for example, most recently in one of the hospitals, we had a 25-year-old female whose only complaint was generalized body weakness. And having that complaint, she was worked up and admitted and developed severe difficulty breathing the immediate next day, was intubated, placed on a ventilator, proven COVID positive, and she passed away on the 3rd day. This makes it challenging because right now that rule must apply, that each and every patient is positive regardless. So what do we do then? The question comes up that, okay, so if every patient is positive, should I close down my facility in order to protect myself? That's not the solution here, and that's not the goal. What we do need to do is take all the general precautions, which we're going to discuss ahead, with every single patient regardless. So just because a patient presents with no respiratory symptoms does not mean you should lower your guard or take it easy. Sometimes we have a habit of just adjusting a certain monitor, or just pulling the screen towards a patient, or I'm just helping them out with a bed sheet, or I'm just helping them on or off the bed without gloves and without the necessary PPE. And this actually might end up being very detrimental. Anyway, coming to now suspected COVID patients with normal vital signs. So So what do we do right now is, because you will hear a lot of centers or a lot of facilities right now saying that they're full and the place is full. And I won't mention specific facilities, but generally this is a statement that you will hear a lot of people mention. So what do we do at this point where every place is full, or where we have nowhere to take these patients? So internationally, what has been adopted, and this is currently being adopted in many of our hospitals here in Dar es Salaam as well, is that if you have a suspected coronavirus patient, but the patient has normal vital signs, you can send the patient home with strict instructions on what are the red flags or what are the worsening symptoms. This includes severe difficulty in breathing, or if they develop any, like the fever is something that is not going down with antipyretics. If, let's say, they lose strength, that the patient, it becomes unresponsive, or they develop any convulsions or any of those sort of symptoms. But mild cases up to moderate cases, of course, you can accept them into your ED or into your clinic with the necessary precautions and PPE. Treat them with what they require symptomatically. And then if they are fit for discharge, you can discharge them with strict instructions on self-isolation. So this includes instructions on isolating themselves from others and isolating themselves from the elderly and medically fragile people in their families, and children for that matter. But how practical is it comes down to an individual to individual perspective and clinical gestalt. Because how practical is it to tell somebody in Tanzania who works as a mboga seller, or who works as a mlinzi and askari, that, okay, I want you to go home, but I want you to self-isolate for 2 weeks and be inside your house? The practicality of these things is something that's beyond my scope of answering as well, is because it's a challenge of every day. But since we are focusing right now on care, what we can do is counsel, and what we can do is make people understand the gravity of the situation. And especially for those people who can, in terms of that this option is available of self-isolation, it needs to be the priority in terms of, for all mild to moderate cases, discharge home with instructions on self-isolation, especially people from our community. In terms of coming to the personal protective equipment now, so remember the principle, be it especially for those who have had emergency medicine training or who have passed through the ED at any point, is we always talk about safety first. Protect yourself. Am I safe? Is the patient safe? Is the environment safe for me to approach? And so safety is always important. The reason why I mentioned this here is because, I mean, we're all healthcare professionals, and well, duh, safety first, we all know that. But then the question arises that in there are situations, I mean, besides being healthcare workers, we are human beings as well. There are emotional moments sometimes. There are moments where emotions, or humanity for that matter, takes its toll on us, and you want to just run in there head first and save a life, or you just want to make a difference at that point. And sometimes we forget. Remember, this is not an ordinary situation. In any situation, safety comes first, but this is beyond an ordinary situation. Therefore, remember, safety does come first in terms of these PPEs, which we're mentioning now. Secondly, for us healthcare workers, I would advise, regardless, I mean, many different studies that are done about droplet spread related to airborne, this disease. But we should consider it airborne all the time, because in the healthcare setting, in the ED, in the clinics, in the hospital, aerosol generating procedures are happening all around us regardless. And people, like, we should consider this disease airborne whenever we are in our facility, regardless. Next, there is the concept of PPE reusing techniques, which is a common question which is asked, is that with the shortage worldwide, especially of N95 masks, can we reuse N95 masks, or can we reuse some of the protective gear that we have? And so I would like to talk about reusing these PPEs specifically in relation to each one that we're going to discuss down here. So the mandatory precautions for healthcare workers is, first of all, a mask, as we all know. So preferably a N95 or a PP100 or a PPF 100. But any mask is better than nothing. So have a surgical mask on if you're in a zone which is not a high-risk zone, for that matter. You can wear a surgical mask and that's good enough. So if you're working, for example, in, well, right now, it's difficult to say because even pediatrics or obstetrics and gynecology or anything for that matter is a risk zone. But if you're working in an area that does not necessarily accept acute intake patients, you can use a surgical mask. Okay. But an N95 is preferable because an N95 tends to form a seal around the face. And that in itself, along with its other qualities in terms of the layering and others, prevents this thing happening. Now, reusing an N95, I will post a link later in this group about a site you can visit, or I'll post one in the MHI group afterwards. But if you visit that, it shows techniques of how we can actually preserve an N95 and reuse it. The important points to keep in mind are, you need to have a plastic bag, like a biohazard safety plastic bag. I'll just get one and show you an example in a bit. So you need to have a biohazard plastic bag in which you can store the N95. That needs to be used solely for that purpose. Removing the N95 has to be removed in the technique that is important in terms of like removing the first bend, the lower bend first and then the upper bend while leaning forward. And remember, before and after. So we have to use the principle we use for eating food. Before and after, anything to do with any of the PPE, you must sanitize or wash your hands or use gloves for that matter. So you take your gloves, you hold the mask, you remove the bands, take it out, place it inside the plastic bag and seal it. And preferably keep the sealed plastic bag in a non-humid area. So you'd rather keep it under the sunshine if you have access to direct sunshine, because UV rays are said to help cleanse the masks. And they also dry them, which is a good thing. So that is in relation to N95s. How many times can you use it? It is said that up to 5 uses is okay, as long as you're doing well preserving it, or up to a week of wearing the same N95. Surgical masks are not recommended to reuse and therefore should be disposed after every use, which is after every 4 to 6 hours of usage. What we're doing currently, the ED, is we wear the N95 and then we wear a surgical mask on top. So what happens is afterwards you can dispose the surgical mask and then preserve the N95, and that helps increase the life of the N95 mask. Adequate eye protection includes either using specific goggles for eye protection, or for that matter, face shields, which as we've seen in the MHI group are available from many different sources. But a face shield is mostly important in case you're doing any procedure, in case you're intubating a patient or doing anything in close proximity. But eye protection, in fact, better than these, they are the specific goggles, which are a better eye protection. Gowns or improvised body covers. So in terms of gowns, there are two types. There are those thin plastic transparent ones, or the thin plastic ones which we normally wear during trauma to avoid spills. So what they say is better something than nothing. And that's the one that normally most people use. But if you see the picture up here, like the person dressed in blue, that is an improvised body cover, which tends to be fluid resistant as well. And if you look at, of course, the picture in yellow, you notice the cover is total. And that is a gown, almost a hazmat, which prevents fluid. So the point here is fluid resistance. So whatever gown or improvised body cover you're using, make sure that it is fluid resistant, and that's the important principle there. Gloves, clean gloves are okay. You don't necessarily need surgical gloves. But what we are recommending currently in our EDs is you wear a pair of surgical gloves inside, and then you wear a pair of clean gloves on the outside, just to have a double layer protection. And because the surgical gloves tend to be tight, they can help cover the sleeve and connect with the gown that you're wearing. Remember, careful donning and doffing of PPE is very important. What I mean is that it's very easy for us to finish a shift and just be like, okay, I'm done, like take everything off. But there is ways to donning and doffing. And again, after this session, I will post some videos which we've made with the Emergency Medicine Association of Tanzania. I think I had posted some already on correct methods of donning and doffing each PPE. And then let's not forget frequent hand washing, which is 20 plus seconds of washing under running water with soap in the classic WHO system of 7 steps, or alcohol-based sanitizer use. Coming to specifically testing for coronavirus, PCRs, as we know, are being done by the government. Remember, there's almost 30% false negatives, so how much we can rely on negative tests? There are some adjunctive tests. So this is actually very, very important for us working here in Tanzania, because we don't have access to PCR swab tests. And so how do I put my categorization of patients into high risk patients, or most probably this patient has corona, is by using these adjuncts, we should say, or these other tests which can point towards having coronavirus. So for example, you notice down here, I'm just going to skip to this thing down here, it says LDH and ferritin. So like I mentioned to you earlier, that heme is broken down by coronavirus. And when heme is broken down, ferritin is released into the blood. And therefore, a very high level of ferritin associated with a high lactate dehydrogenase as well, are some of the markers that are actually seen. And we have tried to do this in many of our cases we've had in the hospital. And we've noticed this pattern that they are very, very high, the LDH and ferritin in these patients. Another thing to consider is lymphopenia, which is seen in 80% or more patients, and also something called the neutrophil to lymphocyte ratio, where you notice that both of these come down. Sometimes if in some patients, so this was a question asked, in some patients, if they have any concomitant bacterial infection going on, like maybe they have coronavirus, but they have also a bacterial pneumonia, or they have a UTI, or they have something else going on, you can have a neutrophilic leukocytosis, very similar to just any other septic condition. So I would personally not advise complete blood count to be an important marker to use. But again, derangements like lymphopenia and leukopenia have been seen as a common trend in many cases. One thing to note about leukopenia specifically, which is a low WBC count, when associated with a low platelet count or with a near normal but borderline low platelet count, get a dengue test done. Because over the last 1 week, especially in Aga Khan, but as well in Muhimbili as well, what we have noticed is a lot of patients presented with leukopenia and with thrombocytopenia. And we all thought, oh, corona. And then we tested dengue, and dengue turned out positive. And it's scary because dengue is back in town. Another thing is, of course, the metabolic panel, which is the creatinine and the urea, as well as LFTs, which show slight elevation of the liver enzymes as well. D-dimer is one of the tests that is also being asked about as well. And what has been seen in D-dimer is mostly when patients progress to a later stage where they actually develop ARDS because of those thrombi that we mentioned earlier. And the hypercoagulable state of the body is where the D-dimer tends to rise. But remember one thing, the D-dimer is a non-specific test because it can also rise in other conditions as well, especially in patients with comorbidities like CKD and others. And so it can be used, but it's not by the rule. Like you can't take D-dimer alone and rely on it independently. Imaging, so chest X-ray is what we have most readily available. Bedside ultrasounds and chest CT scans are other imaging that can be used. Chest X-ray, I'm going to show you some examples of X-rays of corona-positive patients, and we will discuss some of the common things that we see in them. But basically, the early findings, it tends to be hazy. The three things you want to remember and go back with is if there's bilateral involvement, if it's more peripheral, and if there is some central sparing. That tends to be the case in most of the corona-positive cases. The scary part, though, is that in a CKD patient, corona can very much look similar to pulmonary edema. In a sickle cell anemia patient, it can very much look similar to an acute chest syndrome because of diffuse infiltrates. And therefore, it becomes very difficult to actually differentiate between these, and therefore a high index of suspicion is required. Bedside ultrasound, we use it bilateral B lines, but with normal ejection fraction, and you see thickening of the pleural lining as well. But it requires some skill, and it requires a lot of detail, like picking up on details when you do a bedside ultrasound. CT scans are actually the best modality at present, and there is a study that has shown that it tends to have almost as good efficacy as the PCR itself in diagnosing. But the CT scan also has changes according to the time and stage of the coronavirus. So these are some of the X-rays. If you look closely, and you can try and zoom in by pinching into the image on your phones or wherever, you notice that the common finding in most of these cases, just a minute, I'll try and highlight this for you. So you notice for most of these cases, the common finding is we have bilateral involvement in most of these cases, and there is peripheral lesions. So some are very obvious and some are not that obvious. Excuse me for that. So some are very obvious and some are not that obvious. If you look at these images here, you notice there is peripheral lesions which are bilateral and which have central sparing. So this was actually our most recent case, the one down here, where this patient was found to be positive yesterday. And then there was this one where it wasn't basal. It wasn't basal, but we noticed there was a change up here and a change here. And these are some of the things you want to look for and pick up in a patient. If you look at the far left bottom image, like this image here, you notice that it looks very similar to pulmonary edema. And in fact, it was, because this patient had COVID positive, but also had CKD with non-cardiogenic pulmonary edema as well. So anyway, the important thing to pick up from this is that you notice a common pattern, and this should raise a high index of suspicion. The first and foremost most important thing, because we're trying to prevent hypoxia, and our target is a high FiO2. Remember to use non-rebreather mask and PAP and high flow nasal cannula are the next step in this. One important thing to Mukhtar mentioned when we were discussing about this presentation, something to note between the difference between high flow nasal cannula compared to just a normal nasal cannula cranking the oxygen up to the maximum. There's a difference between these two. High flow nasal cannulas are actually devices of their own, which are meant to provide a high amount of oxygen, compared to normal nasal cannulas, which can only deliver up to 6 liters. And it doesn't matter how much you crank it up, even if you crank it up to 15 liters, it's still not going to fulfill the purpose of a high flow nasal cannula. CPAP and CPAP is another measure, and we have also, I'm just trying to look for the link here. There was a study about the difference between CPAP and BiPAP, and BiPAP has been frowned upon. CPAP is okay to use, but BiPAP has been frowned upon because it's noticed that by adjusting, like putting it on a BiPAP mode, there tends to be more aerosol production, and it has not shown to show any benefits in terms of the outcome. Intubation should be avoided. Again, one of the reasons they say avoid intubation is because of these three mechanisms of the pathophysiology that I mentioned. But also remember one thing, that the COVID lung tends to have a different amount of compliance compared to normal ARDS. Like in normal ARDS, intubation is something we rush to as one of the mainstays. But in COVID-19, what has been noticed is that the lung compliance and the tissue compliance and parenchyma compliance is different. So we tend to avoid intubation as being the last resort. And in case you do intubate the patient, other precautions and measures need to be taken. So recently in Aga Khan, we acquired the box where, I don't know if you've seen pictures of it, there's a glass box where you can just put your hands in and intubate. It's, honestly speaking, it's not very comfortable. It's very difficult to maneuver in between that box with the glass, like the glass case box. But these are some measures we have to take. If you're putting a patient on CPAP or on high flow nasal cannula, you have to put them in an isolation room with negative flow oxygen. Negative pressure flow in that room. And in case you intubate the patient, some of the important considerations in your ventilator should be to avoid a high PEEP. So yesterday I sent a picture in the MHI group. I'll share it again. Is because, like I mentioned, the compliance of the lung is different, and therefore, by pushing a high PEEP, pushing a high pressure, we're actually going to cause more extravasation and worsen the condition. And therefore, 5 to 10 is the PEEP that has been advocated to choose in order to facilitate best compliance of the lung. Also, volume control is preferred over pressure control in terms of setting of the vent. Next comes intravenous fluids. So we can use the IVC, which is the inferior vena cava, by bedside ultrasound to guide what is the fluid requirement. But remember, you don't want to pump these patients with too much fluid, because we are also talking about some amount of edema and worsening the ARDS. But at the same time, most of these patients tend to have fluid losing conditions as well. So they've lost a lot of fluid to something or the other, or through hypoxia as well. And therefore, you want to give them some infusion. It's not like you should completely restrict fluid 100%. So slow infusions of fluid are advocated. Antibiotic coverage is important, especially for patients who do have septic signs, like patients who present with very high fevers, or patients who have neutrophilic leukocytosis or other indicators, or for that matter, even patients who do not have those but do present symptomatic. You can give antibiotics, and the preferred antibiotics are a macrolide with cephalosporin. So you can give a ceftriaxone with a macrolide like azithromycin as an adjunct. Broad spectrum is what we're targeting, because this will cover any bacterial pneumonia or any concomitant conditions. Anticoagulation was being discussed earlier. So in the United States right now, they give enoxaparin as by the rule to every single patient who has coronavirus. So enoxaparin is being given, but there is still a study. There are some studies that show that TPA, so alteplase, tenecteplase, or streptokinase, can be used in very low doses, like just a very low dose of 50 milligram is being used in some studies, but it's not yet been advocated by the WHO or the CDC. So it's not advocated into practice. There are just studies still ongoing about this. About enoxaparin, there's more studies that have come up, and they have said that it has some beneficial effect. In Tanzania, currently, none of the hospitals I'm aware of have started using anticoagulant on routine basis for coronavirus patients. Although there was one or two patients admitted who did have enoxaparin given to them, and we do not have the results of the outcome yet. They're still alive. Prone positioning is another important measure which is used. So prone positioning, especially for patients who already show ARDS picture in their lungs. Placing them prone shows better oxygenation and tends to improve the VQ ratio. And lastly, medications. So medications here basically is, what we're talking about by medications is all these things that you might have heard of, the cocktail that's being used, azithromycin, antihistamines, and a lot of other things, including like azithromycin, loratadine, alu for that matter, like even alu is being advocated to be used, and melatonin. So these, I will send this cocktail out on chat on this thing, but there is no proof about these specific medications being efficacious. There is no proof, there is no studies. The basic rule is that use your clinical gestalt, see your patient, see the symptoms that they're clinical gestalt is the main thing. Together with all that, there is also some studies on some monoclonal antibodies and other drugs, which is ongoing as well. This is some of the management. If you see the picture, it basically shows the stepwise approach to the respiratory management in COVID-19. So like I said, start with the initially low grade, which is nasal cannula. And then we can move to a high flow nasal cannula and eventually non-invasive ventilation. Prone positioning when they require high FiO2 and if the X-ray shows atelectasis changes and things. And of course, ECMO is the final option, but the resource and availability of this is a bit of a problem in our setting. In case of pediatrics, it's been extremely rare. We have only had 2 cases so far that I know of. I don't know if there are others. Maybe you can share with us later if anybody has any idea of that. But it appears that COVID-19 does not affect the pediatric age groups as much, and it has a lower mortality rate than even respiratory syncytial virus or influenza. But it is said that children tend to have the virus, but then they don't display symptoms like adults do. So sometimes you might have asymptomatic children walking around with the virus, but not showing the symptoms. And that's why this becomes important to also isolate them or separate them at least from the elderly, because they might actually be spreading the virus while being asymptomatic. Just one point I want to mention of a case that I saw very, very recently was an atypical presentation where I had a child come in with classical Guillain-Barré syndrome with ascending paralysis starting from the lower limbs coming up, the upper limbs, and eventually involving the whole body, and with the classic autonomic dysfunctions and bulbar dysfunction and everything. And we didn't really realize, but then of course we maintained a high index of suspicion just like we do with every case, but we treated it as Guillain-Barré, we intubated the patient was put on a ventilator, taken to the ICU, and the test was done because the ICU had a rule that every patient should be tested when they're being ventilated. And the child turned out COVID positive, which is interesting because there are two studies that have shown case reports of association between Guillain-Barré syndrome and COVID-19. Just adds more stress to the fact that we can't we can't take it easy, because this is real and anything and everything can be COVID-19. So key points for the medical staff here is maintain a high index of suspicion, as now every case is a suspect. Radiological findings are useful. Use constitutional markers like CRP, ferritin, or LDH. Do not forget other treatable diseases. Like I said, dengue is back in town. So don't neglect your patients, because they might have things that are not coronavirus, and you might take it as that and not treat them for those. PPEs for healthcare workers. Advocate for mild to moderate cases to self-isolate with symptomatic management. For unstable patients, prone positioning and delaying intubation as much as possible. And very importantly, avoid fear and stigma. So it's seen in all our settings as well, and I've seen it with my own eyes, but every time there's a suspect, people start backing away that, oh, I'm not going in that room, or I'm not seeing that patient. It's one thing to sit and post WhatsApp stories and pictures and everything about being frontliners and, oh, we are at the hospital for you, so stay at home for us. And another, actually avoiding fear and stigma and standing up and saying that, you know what, I'm here and I want to serve. Protect yourself, safety first, but we have made an oath and we have to live up to that oath. Lastly, before I finish, the do's for everyone. This is again for the general public. So something that we can take forth and advise our patients, families, and friends. Promoting social distance, as we all know, using of masks, which involves the correct use, not keeping them under here in our chin or loosening a strap and keeping it on our chest just so we can eat and drink water. Frequent and strict hand washing and sanitizers. Focusing on building our immunity and health by eating, resting, and exercising, especially for healthcare workers doing a lot of night shifts. We need to rest enough. Talk about it with your family and friends. Currently, it's become, you see those memes that say, oh, you know, I don't remember what we used to talk about before Corona came to town. Well, it is important, especially as a healthcare worker, to talk about it with family and friends. I personally sometimes get frustrated that, like, oh my God, is this all we are ever going to talk about everywhere you go? But you come to realize that we actually stand at an advantage, because our family and friends do not have the exposure that we have, and they do not understand things the way we understand. And therefore, sometimes we might get frustrated, but realize talking to your family and friends about it is a form of counseling and actually helps calm them down more than anything else. Seek medical advice when they need to. So we have the Kojashia Ishnashri Jamaat hotline right now. And currently there is a new thing launched by the KSIJ, which is focused on home-based care. I think we can get more information from the team about this thing. Using home remedies, our grandparents have always advocated for mud and harder and doing mok and all those things. Symptomatic management instead of rushing to the hospitals in panic. So if you receive a phone call from a relative who tells you they have mild symptoms or something, of course we'll all be worried, but rushing to hospitals just to check for coronavirus and then be told, yes, okay, it's positive or it's negative, doesn't really help. I mean, what purpose are you going to serve? The main issue is that if they are mild, then do what I discussed in this presentation earlier over the phone. Tell them to self-isolate, tell them to use symptomatic management, and just be at home and self-isolate. They don't need to, every single symptomatic patient does not need to rush to a hospital in panic. Protect the elderly and fragile, especially those living in extended families where everyone lives together. And most importantly, don't forget to pray. Because prayers, especially now with the month of Ramadan coming upon us, prayers are what will tide us through. The don'ts, like I mentioned, panic. Panic is the worst thing because it does not make you think rationally, and therefore the emergency medicine physician is always taught that the first principle is do not panic. Do not spread false information, or for that matter, do not speak of things that you do not necessarily know about. Do not fixate on what others are doing wrong and focus on conspiracy theories. So I would like to stress this point is that, I'm sorry to say, but let's not point fingers. There are there are things that are going to make a difference in our life, and there are things that are not. So whether I have cases in my country, or whether I have 200 cases in my country, or if I have more, yes, it is bothersome in many ways, and I understand it completely, but it's not going to change the fact that this is a pandemic. It is in our country, needs to be addressed, and we need to do something about it. So let's not fixate and focus on what, oh no, this is not right, and that is not right, and this one needs to do this better, and that one needs to do that better. It's not going to change. So just focus on what you can do, and let's not focus on conspiracy theories. Advocate for relatives not to visit sick relatives in hospitals unless absolutely necessary. Touching our nose and mouth and rubbing our eyes and things like that should be avoided. Avoid going to the hospital in serious cases. So this is a don't. So basically, this is kind of different from the other point I mentioned, is that some people, the patient is very sick at home, maybe with some other condition, but they don't want to go to the hospital because right now they've heard if hospital majasu, so then we will be taken away by the government. That is something that's going to cause a lot of complications at home. If somebody is serious and needs hospital care or emergency care, take them to the hospital. Like, don't avoid going there just because of fear of being taken away or something like that. This is something, again, don't wear gloves or other PPE meant for healthcare workers in public. You've seen people walking around with N95s on the road, people walking around wearing gloves, carrying their fomites from one place to another and spreading the virus even further and spreading other bacteria and God knows what else. So we need to advocate this as healthcare workers. Like, people should not be wearing gloves and other things in public or in office spaces or other places where they don't need to. They should be washing their hands and sanitizing. Overall, we need to prevent the spread of coronavirus. And I think at this juncture, I'm sorry I took quite a bit of time, but I think we have some time. We can answer questions quickly and have a brief discussion before, I think hopefully before namaz time. And so now I think I'll open the floor at this point. Orujul?
Yes, thank you, Hussein, for the nice presentation. So, does anybody have any question regarding topic? So, if you have any question, you can just unmute your mic and ask the question. It seems like everyone is.
We don't have any questions. So we had a couple of questions on the Google Forms. So if nobody has a question, then maybe we can address some of those quickly.
Yeah.
So we had 8 questions, but I'm just going to filter these. One question we had was, what precautions should a person take if they are a COVID suspect themselves and isolating themselves at home? So the point is simple, that they need to self-isolate from anybody at risk. That includes their family, the elderly, and children and all. And they need to do symptomatic therapy. And in case of developing any severe symptoms or anything that's life-threatening, they need to contact the appropriate sources, which is either calling the hotline or going to the emergency department or the hospital. There was another question here that says, it says, I'm a healthcare worker in a country that is affected by COVID-19. I'm experiencing anosmia and acusia for the past 4 days with no symptoms of fever or cough. However, I did have chills and nausea 1 week ago, which resolved in 2 days. my full blood picture from 1 week ago was essentially normal. What is the next step I should take? So I think this is a good point, something that actually reminded me, a point that I need to mention, especially for us in here in this group, is that, so currently while you're working in this field, it's very easy to get paranoid. I've had that moment where I sneeze at home and, you start turning around and looking at each other and being like, okay, we all tend to be very paranoid because of everything that's going on. And sometimes we say that, the mind controls what the body feels. And remember that other viruses also exist, and other things also, other bacteria and other things are also there. Especially recently, for those using the masks, the N95 masks and things are causing a lot of sinusitis-like symptoms. Excessive number of shifts and stress are causing a lot of fatigue. I myself I'm just recovering from some symptoms which I was very worried about recently. So to this question specifically, if you experience anosmia and ecdysia for the past 4 days, but no fever or cough and things, and then 1 week ago you had some symptoms which resolved, and currently you are fine, then basically you're fine. If you develop any symptoms, you need to follow the same precautions that you're going to give anybody else, which is self-isolation and taking symptomatic therapy. But if you do not have any symptoms, then you can continue with your work, taking all the necessary precautions, and you'll be completely okay. The main thing for us is to avoid letting our mind play tricks on us, especially being in this field. As long as you're taking the precautions required, wearing the PPE required, we will be okay, and we won't be as exposed as our heads might tell us that we are. Some people have asked about Ramadan specifically. So our normal programs of food and other clothes distribution and things, how different should it be this year considering all the risks? And somebody else asked, what about buying meat, poultry, as well as fruits and vegetables? So currently, and there was also a question on pets. So currently there is no proven study on corona being spread from pets, if you look at the literature. Fruits and vegetables, as well as meat and poultry, there is no spread unless, of course, there has been a direct spread in terms of fomites or droplets. So it's always good to follow the same precautions of washing all our fruits and vegetables and our meat, washing it and cleaning it. In terms of in Ramadan, how to do the clothes distribution and these things, I don't think it's my area of expertise. So I think there will be people, maybe somebody like the MHI can come up with an idea on how exactly we'll do clothes distribution and maybe other drives without actually getting involved physically. Alia has posted a question here. I don't know how relevant, but I'm sure most of us are around people in our community who let maids in their house. And yeah, so related to maids in the house, as we all know that Tanzania has very very tough control in terms of the Mwendokasis and the daladala stands and the exposure outside, especially with the recent advent of Amana and other things. So the thing is that, like I said, a high index of suspicion is not just in the hospital, it's each and every person, each and everywhere. So maintain your social distancing no matter where you are or who you are with. Wear your mask in any area that you're in which involves interaction with anybody else. And wash your hands and sanitize your hands all the time. If you have maids, you can give them the option of either staying at your house if you really need them, like they can probably stay there and sleep at the house as well, and you can pay them for that accordingly, or give them leave, in terms of give them paid leave, like let them go and be at their home and advise them self-isolation. Again, it is the solution that I can propose. Like I mentioned earlier about even the self-isolation of Tanzanian patients, like advising them. The practicality of things comes down to an individual to individual level. It's like, I cannot tell you to do the same thing I do in my house. in your house because you know best what would work for you. But definitely the risk is there. And so don't take anyone for granted. That includes our drivers, our askaris, our maids. Don't take anybody, including if you are living in buildings which have other neighbors and other people. The lifts that we use, all those things, we need to take precautions at every step. It may seem like we're doing too much, but it's required because it definitely will play a role in infection prevention. Related to other people, that's the advice you can give them. You can tell them to either keep their maids at home or tell their maids to go home. But this movement to and from every day, the way we are used to, is something that should be avoided. Negative pressure flow in isolation areas. Thank you, Abbas, for the question. So negative pressure flow is basically built-in systems where the pressure in the room is sucked out through the vents, and there are specific facilities that are made. So you need to have a talk with the hospital administration about actually building negative flow rooms, because that is what ideal isolation is all about. So as far as I know, in Aga Khan, a negative flow isolation room is available, which is specifically built. So I'm not sure about the other hospitals, but that is something that needs to be advocated through the hospital management. I hope that answers your question, Abbas. It's not something we can do as healthcare professionals specifically. It's something we need to talk to our hospital management to do. Mohammed Zaid, thank you for your question. Can you kindly explain the risk of reinfection and the severity associated to it? So reinfection and the severity. So there are multiple studies going on currently about this that say that that talk about patients who have had symptoms and then it's gone away and then they've redeveloped symptoms. So there are two theories that have been associated with the literature I have come across so far. And of course, other people are welcome to contribute to this. One is that relapse is a major factor in COVID-19. So if a person recovers because the viral load in their body achieves a substandard, so the viral load goes really low, and therefore they become asymptomatic, or they recover for that matter, or their viral load becomes so low that they are not detected by the tests that we have available and therefore are classified as negatives. And then what happens is some factor or the other causes their immunity to drop. And therefore they have a relapse of the viral load that they have already and develop COVID again. So that happens with the same strain. Reinfection, according to another paper, is possible if the strain changes in itself. So they are saying that apparently there is a theory that not just one strain is associated with COVID-19, with this coronavirus specifically. And that's also the reason why they're questioning developing innate immunity, developing immunity to this having been infected. Because you could get infected and then you could get infected again. You're not completely immune to it after having developed antibodies to it. Sorry, let me just check this. So you talked about treating all patients as COVID. I'd like to know your opinion in terms of testing patients in peripheral health centers. Some have no diagnostics, can test for CBC and X-rays only. What will you advise these health professionals to do? So Mariam, thanks for that question. In peripheral health centers, where there's only X-rays and CBC, so my principle on COVID-19 is that it's so much more of a clinical diagnosis to start off with than anything else. In terms of, so like I said, of course, there are associations with other cases, there are associations with comorbidities, with other presentations and other things. But if you look at the spectrum in terms of the percentages, 80% of the patients will present with those constitutional symptoms that I mentioned, like 80% with a cough, around 50% with a fever, and around 20% with shortness of breath. When you work in a peripheral health center, establish that every patient is COVID positive. Every patient who has mild to moderate symptoms, treat them in the same way that I mentioned. Give them symptomatic therapy. Do a RDT if you need to do an RDT. Do a full blood picture. Do a chest X-ray. If you have a chest X-ray like similar to the one I showed, which is high index of suspicion, or you have a full blood picture which shows leukopenia. Let's say you did a dengue test, you did a malaria, you ruled out everything else. You did a UTI, especially for the females. You ruled out all other septic foci. Now you're thinking, well, this looks viral. Well, currently, if it looks viral, there's only one virus that's being, well, whatever. I won't use other language here, but there's only one virus that's hitting people the hardest right now. And so treat it as that. But that does not rule out working up the rest of the things. So do an RDT, do a dengue test, do your full blood picture, do a chest X-ray. Any indication of corona and your patient is stable, follow the same principles I mentioned. Discharge them with symptomatic management, tell them to go home, self-isolate. If they get worse symptoms, tell them to go to a facility that can cater for those worse symptoms. So for example, let's say if I have a patient in a clinic, in a polyclinic, I tell them, okay, fine, take paracetamol for your fever, take some celestamine, have a bit of maybe some loratadine, whatever, go home, self-isolate, 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 wash your hands frequently, social distancing, etc., etc., etc. If you develop difficulty breathing, which is really bad, or this happens, or that happens, I would advise you go to a higher facility. So these things are the advice that you can give at a peripheral level. Because one major problem we're facing right now is everybody's saying that, okay, you have this, go to Amana, go to Amana. Everyone go to Amana. If everybody goes to Amana Hospital, including the CKD patients, and including our sickle cell patients, and including our heart failure patients, and including every other patient, and every pediatric patient who presents with respiratory symptoms, there is only so much one hospital can take, right? So mild to moderate cases, treat with symptomatic management, discharge them home. Only severe cases will be catered to by the healthcare workers. Our facilities won't get full. Our isolation facilities will be handling a good amount of patients. The only flaw in that will be the reporting, which, well, it's very effective so far. Farhan, can we discuss about the use of pulse oximeters that's happening in the group the other day? Farhan, can you elaborate on this? If I might not have followed specifically the discussion, so
Hello?
if you can unmute and just,
Yeah.
yes.
Can you hear me, Hussein? Yeah. So the other day we were discussing in the group. I mean, it's a bit of a tricky situation, right? Because on one hand, they're saying that if you have mild or moderate symptoms, then self-isolate and be at home. And I think this was brought up in the group. And on the other hand, we said that sometimes the change is so quick and so steep, and especially with regards to shortness of breath, they are silent hypoxic. So how do we advise people to manage that? And on the group, people were talking about, oh, maybe we should tell people to have pulse oximeters at home to track that. So just how do we meander, or how do we deal with it?
Okay. So again, there is no black and white answer to this. Like, I can't tell you that this is what you should do and this is what you should not do. If you were following the talk earlier, like I said, that such advice, for example, goes very much on an individual case-to-case basis. So I'm not trying to say that, like, okay, aloka differentiate and aloka nati, but when you face a patient in front of you, based on how that patient presents to you, and also based on a lot of other factors like the home environment, a lot of factors like the education level of that family, of that patient itself, these are factors that will come into play. The occupation of the patient, these will come into play in the sort of advice you will give the patient. So for example, let's say if a patient comes to me who lives in a support center, nursing home for that matter, and I am thinking of facilities, I'm not talking about I'm just giving a general scenario. Let's say you have a patient who comes from a nursing home and you're thinking about facilities and home environment and other factors, and the potential of the sort of people who live there as well as potential high risk candidates, then probably going back home and self-isolating is not the best solution. So for that, right now, as far as I know, the Jamaat is trying to work on specific isolation facilities to try and help people be isolated, but then also be able to get service and care. But for the general patients that present to us, especially from our community, educated folk who you can advise, maybe having a pulse oximeter at home, yes. Or you can advise them to do timely routine checks in terms of like they can use the hotline and report time to time. Or families that have a healthcare professional in their house, which actually, if you take the number of people in our group itself and you extend it to our nuclear and extended families, covers probably half or more of our community. So, like I said, I can't give you a straight up answer, a black and white answer to that question, but it really depends on clinical gestalt and individual cases, on how they come to you and who you can give this advice to and who you can't. I don't know, I hope that answers your question.
Yes, it does, Hussein. Thank you.
Okay.
Hussein,
I don't see any more questions
I
here.
have a question. What is your opinion on healthcare professionals using cloth face masks? I mean, including the filters. Like there are some cloth face masks which have like 2-3 filters in the middle. So is it like as sufficient as the surgical masks, or is it like different?
So the cloth masks, regardless of the number of filters, if you're working in a healthcare setting, are not effective. I'm sorry to say. Currently, actually, because of the short supply, I should say, or because of the demand and supply thing and all, we are falling short everywhere, including like recently one stock of masks in the EMD was of the similar sort, which we advocated against and we got changed. The simple answer is no. Cloth masks, regardless of number of layers, do not provide protection from patients. Cloth masks provide protection to people in terms of your droplets not going forth. So if you are infected and you don't want to spread your droplets, well, that's one thing. But when you're working in the healthcare facility, any patient is potentially a suspect. You cannot rely on a mask that does not give you protection towards you. And so for that answer, it's a no. Surgical masks can provide that, and N95s and P100, like PF100, and those masks are advocated for that use.
Thank you so much, Hussein. So I think there is no more questions. So thank you very much for the amazing presentation. And I've seen we've also received some good feedback in the comment section from the participants. So we will try having more talks like this in the future for the professionals, as well as now we are also planning to have one for the community members. So I hope everyone enjoyed the session, and thank you very much for joining. So I have been recording this session, and as soon as like I have edited it, and I will keep it up in our YouTube channel. So whoever was not able to participate in this can go to our YouTube channel. So thank you very much, Hussein, and thank you everyone for participating in this.
Okay. Thank you very much.
So I guess this is it.
Thank you.